see the patient, see the screen. Then starting with the long head of biceps tendon, supination, sometimes a little bit of external rotation, and putting the probe between the two tubercles of the humeral head will allow you to see the long head of biceps tendon in the middle, just the arrow. Okay. So long head of biceps tendon, lesser tuberosity, greater tuberosity. As Levin mentioned, the first thing we want to see is if first there's a tendon there. Is it torn? Is it retracted? And is there fluid around it? And if yes, where is the fluid coming from? So as you're scanning down, you usually have to tilt the probe a little bit to keep good echogenicity and play with the anisotropic feature of the long head of biceps tendon. And you want to scan down until you see the pectoralis major tendon, which corresponds usually to the myotendinous junction of the long head of biceps tendon and muscle. And medially, you'll see the short head of biceps muscle. So this is kind of the butterfly or the hourglass image that you're looking for to make sure that there's no torn or retracted long head of biceps. As we go back up, we can add a little bit of extension, okay, and go into the rotator interval area that Levin described very nicely. We can move all the way up until we see the coracoacromial ligament, and then back down just a little bit and try to identify the structures, the ligamentous structures that Levin showed us. So basically on an image here where we freeze, in the center of the image it's the long head of biceps tendon. We see the humeral head, we see the dark line over here is the cartilage overlying the humeral head. Medially you'll have the subscapularis tendon, laterally you'll have the supraspinatus tendon, and then the area over here, this is where you have just underneath the long head of biceps tendon, the superior glenohumeral ligament, and then over it, the medial part of the coracohumeral ligament, and then coursing over the long head of biceps tendon, the lateral part of the coracohumeral ligament, extending laterally and posteriorly into the joint capsule and forming the rotator cable. So in some patients we see it very clearly, in others a little bit less. Here we're quite lucky to be able to see it quite nicely, and as Levin mentioned, overlying all of these tendinous and ligamentous structure is the deltoid muscle. The bursa here is the very thin line, I don't know if this is measured, just over here. So thin black line, usually less than 2 millimeters, is considered normal. Then we move to the subscapularis tendon. So with a little bit of external rotation, keeping in the same plane. So we were looking at the long head of biceps tendon. Then we externally rotate and we can see the subscapularis tendon. We can scan it caudal and cephalad to make sure we evaluate it on all its height. We can go a bit more medially and see if under the coracoid there's any signs of pathology. We can do dynamic maneuvers, either passively or actively, to see if there are signs of subcoracoid impingement. At the lateral side of the coracoid, we see the origins of the coracoacromial ligament if we just pivot the probe up towards the acromion. So this is the coracoacromial ligament. The coracohumeral ligament has its insertion just a little bit deeper and is sometimes harder to follow all the way from the coracoid to the rotator interval that we were looking at before. Once you've looked at the subscapularis tendon in long axis, you can pivot 90 degrees and look at it in short axis. It usually has different bundles, 5, 7, with some fat in between. That's usually a little bit hypoechoic. So all the way to the distal antithesis, and then we find the long head of biceps tendon again. So like this, you've surveyed quite well the subscapularis muscle and tendon. We can give a quick look at the AC joint. The patient can relax. So medially the clavicle, laterally the acromion, the dorsal acromioclavicular ligament, the articular disc of the AC joint that you can look at also in long axis. It requires a bit of stability to make sure that you're really in that joint space. Another maneuver you can do once you've scanned the joint from posterior to anterior and vice versa is asking the patient to do an active adduction to see if there's any gapping of the joint or instability. So if you move like this, usually there's some movement, but nothing quite significant. If you have any doubt, you can compare with the contralateral side if it's asymptomatic. Then, moving into the supraspinatus area, we'll ask the patient to go either in modified CRAS or CRAS. I have a personal preference for just a modified CRAS and asking them to keep the elbow really pointing backwards without too much internal rotation, because this will hide a lot of the supraspinatus. So starting with a transverse view of that area, you can scan up from the lower deltoid to make sure that you're not missing any cuff distally, and then arriving on medially, we keep the long head of biceps tendon, and what we want to see is that tire on the wheel. So the wheel is the humeral head, and the tire is the rotator cuff tendon, so the supraspinatus, and then the infraspinatus. As you know, they kind of crisscross in an area around 2 centimeters more posterior to the long head of biceps tendon. In some patients, we see the facets of the greater tuberosity quite well, and usually the superior facet is exclusively supraspinatus. The middle facet is a mix of supra-infra and then infraspinatus, and the posterior facet will be the teres minor. So here the echogenicity of the anterior bundle of the supraspinatus is very, very nice. No signs of tear, no signs of bursitis, no signs of calcification. The insertion distally at the antithesis is very regular. And once we've done that, we can pivot 90 degrees to look at the long axis of the supraspinatus first. The good tip is to find medially the long head of biceps tendon to make sure we don't miss any of that anterodistal area of the supraspinatus where there is most pathology. So like this, you have the bird beak appearance with the superior facet of the greater tuberosity with the supraspinatus tendon, the bursa, the deltoid muscle. And we move posteriorly, you'll see the shape of the bone here change as we transition from the superior to the middle facet. And usually in this area, we're transitioning into the infraspinatus. A good way to look at the infraspinatus tendon is either an internal rotation, but also when patients are able to withstand it, to have a little bit of flexion and adduction, puts the tendon in a quite a straight course. So basically here, I'll just go muscularly from, this is the spine of the scapula, this is the infraspinatus fossa. All of this here is the infraspinatus muscle. Below it, the teres minor muscle, and we'll follow that central tendon that will insert just over here on the greater tuberosity. I'll put some more gel and I'll show you the long axis picture that it gives us in that position. So all of this here is the infraspinatus tendon antithesis, and the advantage of this position is we have quite a straight course. So in terms of anisotropy, there's less change within the tendon to look at it from both the antithesis and the intramuscular portion. If the patient was to internally rotate, we have a bit more rotation to do, coursing quite anteriorly to find the infraspinatus antithesis over here. And once this has been done, you can add some depth, lower the focus, and we can survey the posterior glenohumeral joint. No focus, okay, autofocus, that's good. With the posterior humeral head, the glenoid, the posterior labrum, the spinoglenoid notch with the suprascapular nerve, again the infraspinatus muscle, the posterior deltoid, looking for any type of fluid, labral anomaly, paralabral cyst, cortical irregularities. You can do some dynamic maneuvers over here to see if in external rotation you will find any fluid in the posterior recess, which is not the case over here. Okay. On top of that, if you had any doubts on the supraspinatus tendon, if it was torn partially or completely, you can also assess the supraspinatus fossa to look at the supraspinatus muscle over at the trapezius superior. Looking at it both in short and long axis is recommended to get a better idea of potential atrophy or fatty infiltration. After that, you can do dynamic maneuvers depending on the clinical presentation. The classical subacromial impingement maneuver has been described by radiologists from my center, Nathalie Bureau, Thomas Moser, and Etienne Cardinal, where you basically passively abduct the shoulder and you look for any signs of impingement, so either bursal kind of thickening correlated with pain, or a calcification that would block the movement in that movement, which is not a fantastic maneuver. It's best to have patients do the painful movement dynamically, actively, looking at the acromial ligament here in long axis. You can ask the patients to do internal, external rotations and looking at the subacromial space to see if there's any snapping, like in the video that Levin presented. So if you go like this and move like this when I tell you. So this is the advantage of ultrasonography. You can pretty much do anything and go. So this is analogous to what was shown in the video. You can continue to move, looking if there's smooth gliding under the coracoacromial ligament, seeing if there's any snapping, any bulging correlated with pain. So these are fantastic dynamic maneuvers for impingement with ultrasound.